Yeah, we are on live. Suman, we can start the program. We are on live. Hello, Suman.
Can you hear me?
Yeah, now we are hearing you. Yeah, we are on live. You can go.
Good evening, madam. I, Shuman, on behalf of Shield Healthcare, welcoming you and all the participants in today's webinar. And the topic of today's webinar is menopause and its treatment perspective. So before moving into the webinar, I must introduce our Shield Connect page. That is our knowledge sharing page. And here you can find blogs written by eminent doctors across India. And this is the blogs. And here you can find the upcoming webinars and past webinars. And in past webinars, these are the webinars done by eminent doctors from Shield. And we have also some awareness that is immune booster and PCOS awareness. And this is the immune booster means webs for the different blocks related to the immune system. And here are the PCOS awareness program, and here many doctors give their valuable suggestions on that topic, and it is available in different regional language, like you can see that is Hindi, English, or Tamil, or some other language also. And this is the most important things. These are our key opinion leaders. Almost 250 leaders across the country is now supporting us. So now it's time to start our webinar. And as I previously mentioned, today's webinar topic is menopause and its treatment perspective. And today's our guest speaker, Dr. Lavanya madam. It's my pleasure to introduce madam. Madam did her MBBS and MS Obstetrics and Gynecology, Fellow Reproductive Medicine, PG DMLE. Diploma in reproductive medicine from Germany, senior consultant obstetrics and reproductive medicine and robotic surgeon. Madam is the IVF unit in charge, Narayana Health Hospitals, Bangalore. Madam graduated from MS Ramaya in Medical College, Bangalore, MS Obstetrics and Gynecology from Kempenguwada Institute of Medical Science, Bangalore. Trained in obstetrics, ultrasound, Fetal Foundation of India, Bangalore. Trained in laparoscopic and hysterectomy surgery and robotic surgery. Madam guided for DNB thesis for last 7 years, and she is a Foxy Award winner 2019. Madam got several awards to her credit. Dr. Valagangadhanath Swamiji Samaj Seva Award in the year 2015 and 16. She was facilitated by Sangeeta Mobile Limited for the contribution in women empowerment. Madam received Chairman Award for Distinguished Service Doctors at Narayana Health 2014 and 15. Received Kempenguwada Award for Samaj Seva. Awarded as surgeon with least learning curve for robotic surgery in the year surgery in India 0917. Madam is the Joint Secretary of KISAR 2019 to 21 and founder member of Karnataka chapter of Indian Fertility Society 2019. Madam is the member of many governing bodies like ACE, BSOG, ISAR, and PCO Society. Apart from that, Madam has several research papers in international journals of weight repute. And apart from that is many patents to her credit as well. With this short introduction, I am handing over the session to Madam, and I request all the participants for their active participation. And I would like to request you to post their queries on the QA section of Shield Connect page. And once the webinar will be over, so we shall have a short discussion on the topic with Madam. So thank you, Madam. Over to you.
Thank you, Suman. Thank you so much for that wonderful introduction, I would say. So before I start at the offset, I think I would like to thank Shield for this wonderful initiative. It is so nice to know that you're across the country. You've been involving a lot of clinicians across to share this knowledge, though, you know, we are all sitting at home feeling bad that, you know, we're not able to meet our friends, a lot of academic things. It's so nice that the Shield has got the academic sessions to us at our comfort, at our homes, at a convenient time to log in, because I see there are such nice, great clinicians in their panel, every day speaking about something, writing blogs. Congratulations, Shield, for this great initiative that you have taken. So coming to today's, and I have been given a topic on menopause and its treatment perspective. I think it's a wonderful thing that we need to know about menopause, because we can see that the lifespan in India is increasing. We have a lot of elderly care. It is initially, we would see it only in the outside country, that a lot of elderly care was happening. More of the elder populations were there. I don't think India is lacking anymore. So we can see a lot of elderly population or post-menopausal number of people increasing. So their health becomes our concern as well. The WHO defines a natural menopause as a permanent cessation of the menstruation more than 12 months, consecutive months of amenorrhea. In general, the natural menopause can occur anywhere between 45 to 55 years of the age. And they say it's an average in the mean, in an Indian, anywhere between 40 to 50 years, it can be ranging. Of course, it varies. And the Indian National Family Health had done a survey saying that the number of people were increasing, the postmenopausal women were increasing, and 80% of the current married women fell in the group of menopause. So they had extended their studies so well, and such a nice study that they had done. They could precisely tell us there were almost 3.1% of women who belonged to the age group of 30 to 34. And there were almost 8% of women falling between 35 to 39 years. So that means, are we talking about premature menopause? Yes, definitely. There is a very high incidence, even because I practice infertility, I can see a lot of women who have postponed their marriages for several reasons. When we check the AMH, we see the antral follicle count, we can see it's so low. So they're all premature. Menopause is increasing in higher numbers, and this is supported by National Family Health Survey in India. And they're saying, in one of the studies which they had conducted exclusively in Andhra, they said 22% of the women were between 35 and 39 years who had attained menopause. Of course, the study didn't bifurcate between natural menopause and the hysterectomy being done. So the data didn't have the differences. We also have a lot of other studies in the Indian Journal, medical journal, where they said there are increasing number of post-menopausal women are increasing. And they said right now there were around 96 million in the 2011 census that they had done. And they have predicted almost we can end up having 401 million in 2026. So imagine the number of post-menopausal women we are having. Why am I giving you the statistics of that we are concentrating, or we're going to end up having a lot of more post-menopausal women? Is because as the age increases, forget alone the menopausal symptoms, the things you have to deal with, that associated with an age factor, they are at very high risk for hypertension, heart disease, osteoporosis. The quality of life keeps coming down in this group of people. So we have to be very careful, because again, it is aggravated with menopause getting added onto their existing life. So doesn't mean that everybody who's going to be postmenopausal, perimenopausal should be having symptoms. Quite a few of them can be asymptomatic, quite a few can be having symptoms. So, but then how do we approach? We have to do a holistic approach. We have to look at preventive health, because we know in the coming years we are going to have a lot of postmenopausal people, a lot of perimenopausal people. So let's do a preventive health approach to see how do we make life better for all these people who are around us. So what are the symptoms that any of these people could be suffering? So vasomotor symptoms is the most common thing, and you know about the hot flushes that comes. I'll be going into detail about it. Somatic symptoms, genitourinary symptoms, you all know, you have had at least 2 lady in a day walk in complaining about the genitourinary syndrome into your OPDs. Neuropsychiatric symptoms, because forget alone the pandemic and a lot of people being at home, the amount of workload that she's taking along with her age, along with her symptoms, a lot of home responsibilities that a mother or an elderly person at home will be dealing with, it can be really crazy. So we'll have to do a holistic approach for her. So let's look at preventive health and see how do we make her feel comfortable. So as the perimenopausal age group approaches, the cycles can become longer, shorter, interval between the two cycles can vary, a little irregularity in the cycles will start setting in. Sometimes people have amenorrhea for a longer duration and they start bleeding. Sometimes the bleeding is heavy, sometimes the bleeding is scanty. All these variations starts. That itself can be disturbing for her. And to make this worse and cause more anxiety, along with the variation in the bleeding and the pattern of the bleeding, the vasomotor symptoms can be really bad for them, because there's a sudden flow of blood into their face or to their neck, chest, and they can start sweating profusely. And sometimes when they're in a group of people, they can see that they're the only one who's sweating and somebody else is actually feeling cold. So all these variation in the sensation can be there. That is because of the increased blood flow leading into peripheral vasodilatation, and sometimes it can lead into finger toe peripheral dilatation, causing raise in the skin temperature, hot flushes, and sometimes it can be associated with palpitations also, because all these things are happening. The cardiac heart rate increases. The heart rate increases to anywhere between 10 and 15 beats per minute, so she can start feeling a palpitation, and that can also cause a lot of anxiety. And again, the same, it becomes a vicious cycle of anxiety, vasodilatation, hot flushes increasing. And this symptom, once it starts, can actually remain, that cycle can remain for 30 minutes or a little longer, causing a lot of disturbances. So here, like I said, these symptoms, the perimenopausal symptoms, can start almost 5 to 6 years even before she attains a menopause, and can persist for almost 5 to 6 years after she's menopause. So that's like a 10 long years for her. And several studies have been done of how this vasomotor symptoms appear, disappear, when does it happen, and they've all substantiated, saying that it is an average of 10 years. So roughly 5 years before and 5 years later, these symptoms can remain in the median of 10 to 11 years. Along with that, the somatic problems of the joint pain, joint ache starts. And sometimes it leads into obesity. Along with this joint pain or the progressing age, it can also lead into depression. So once anybody is depressed, all these symptoms, be it the vasomotor or be it the somatic of the joint pain and the muscular cramps that they suffer through, they say, I'm not able to sleep because, I'm getting cramps. I'm not able to walk. I feel a lot of loss of sensation while I'm walking. All these things increases as the perimenopausal age group starts appearing and gets worse post-menopausal. And these experiences can actually be devastating for any woman. And again, added to this whole thing, to increase the depression, is the body composition starts changing for her. There's a lot of obesity which starts accumulating mostly on the abdominal area. This not alone, forget the body composition changing, the worst part is it starts accumulating on the abdomen, which leads into lot of more cardiac problems for her. The abdominal ratio configuration that is happening, and if this is central obesity which increases, she's naturally going to be prone for cardiac problems, and then the estrogen also comes down. Again, a beautiful woman can start becoming, looking a little different. Of course, it's a question of acceptability. How do you train yourself? So I always say, let's gracefully become older. So you cannot change. So start accepting, yes, this is a process of the aging, and if you're prepared, you will accept the changes that go through your body. So you will be prepared well in advance. And this is how you need to comfort any woman who walks into your OPD, telling her, yes, it is common, because you can see a lot of people walk in saying, people may not complain because of the wrinkles, but they can complain of a lot of skin texture changes. They say a lot of darkening is appearing on the neck or on the cheekbones or on the eye, the frontal region, the temporal region, and all. They start complaining, and this is all because of the estrogen deficiency, leading into the decrease in the collagen content, and that is how the skin becomes more wrinkled and lot of baldening starts. Hirsutism can be there at the wrong places. This is why she comes back and say, look, my hair growth on the facial hair is increasing, but then I'm losing a lot of hair. So it starts becoming very frustrated for her. So it becomes our duty to reassure her, saying that yes, this is all because of the estrogen deficiency. It's a part of the process. And then yet some people may overlook a lot of cosmetic things or their look. But then what they cannot help is the genitourinary syndrome that a menopausal woman goes through. So what happens most of the times, they come back and say they go through a lot of dryness in the vagina. There's a lot of increase in the frequency of the urination that happens. This is all because of the atrophy of the vagina, which happens. The lining of the vagina is lost. The rugae of the vagina is lost. So what happens? There's a balding in the vagina happening. So once it loses, the texture of the vagina is lost, the collagen even in the vagina starts reducing. She starts feeling a lot of heat there, a lot of burning sensation there, dryness, which also changes the pH. And almost 32% of these people complain with vaginal dryness. They can have pruritus vulvae, between 10 to 20% of them complain. Urine urgency starts increasing, and this burning sensation itself will make her feel like going to urine, and almost 10% suffer with this. There are almost 10 to 15% of people who starts having dyspareunia. They of course want to have a healthy sexual activity, but because of this dryness in the vagina leads into a lot of frustration. I do have quite a few women between 50 and 60 years come back and complain that they have dyspareunia. Their partners have a lot of complaint. So we need to respect each one's demand and see what is their need and try to help them. But it is very important that we also rule out any other pathological problems are there. So you have to make sure you examine her, make sure a regular pap smear is done. You have to examine, is there any lesion? How does it look? Local examination needs to be done. Speculum examination needs to be done. Rule out any associated pathologies. See if they have a vulvovaginal atrophy. Is all these symptoms coming only because of the reduced vulval fat, or is it because of the vaginal rugae is being reduced? The blood flow of course reduces with the increasing age, which you can make out with the pale appearances. And because of all these changes, the pH also in the vagina starts changing. It becomes more on the neutral side. The acidic range reduces. This can lead into a lot of bacterial infection for her at all. Because of this, vaginal maturation index starts dropping for her. We can give them a temporary relief by using vaginal lubrication. Vaginal moisturizers can be used. We'll give her a little relief with the vaginal dryness. Dyspareunia can help her. But what can certainly help her is the local estrogen therapy, which can be used as the first line. And you can see that they feel so comfortable because they will not experience any more vaginal dryness. At least the blood flow starts increasing. They don't have that burning sensation. They all come down as soon as you start giving them a local vaginal application. But it is very, very, very important when you write a estrogen cream, if we have to be dealing with simultaneously an ovarian tumor or estrogen tumor. So you will have to evaluate thoroughly and just not look at her vagina and write some estrogen cream and send her back. So whenever you're putting any lady on an hormonal therapy, make sure you evaluate her so that you don't make her or push her into another complication. Coming to the sexual problem per se at the perimenopausal and postmenopausal can be devastating for quite a lot of them, and very, very devastating for the partner also, I would say, because a lot of women come back and say her partner is not happy because of all these things. Or we have a lot of men come back and say, my wife is having these problems. It's causing a lot of emotional trauma or a lot of mental trauma that they go that happens with both of them. Again, estrogen therapies can be tried along with the estrogen therapy. And this is why I said make sure that you judiciously use it and evaluate if there are any problems. There are not many estrogen testosterone creams that is available in India adequately, at least not at the people's reach conveniently. So this is what is very important. The alternative and the testosterone preparations are not available. What can we use as a clinician? How do we comfort our patients is very important. The easiest and the low risk of the hormonal therapy is a tibolone, which is a good option, I feel, where it does have an androgen activity. And this can be used if our women are suffering with the libido problems. I will come into the tibolone in a little detail. Again, with the increasing in age, you know that there are a lot of CNS changes which starts happening. And one thing, her or maybe more than her, it's the family which needs to deal with, is the dementia, because a lot of cognitive effects starts setting in. The memory comes down, the communication, the language starts becoming a problem, ability to focus starts varying. They cannot pay attention to something that you're talking out, they cannot reason out, the judgmental power starts coming down. Lot of times even the daily activity starts suffering, visual perception, everything starts changing for them. So they need a lot of psychological support at this time. So be very patient with them. So this is why I said holistic approach, preventive health approach is what we need to look into it, because you cannot treat that women alone, because you have to talk to their family members. So it becomes more of a family medicine care that you are expected to give. And I'm sure all the gynecologists who have logged in today will agree that our field itself is like that, where we focus on the family. It's a holistic approach for the whole family, especially it's a perimenopausal age woman we are dealing with, because she's the most eldest in the home. It could be your mother or it could be their wife who are dealing. So she's the one. If she's healthy, the whole family runs healthy. So you have to concentrate, make sure others do not irritate her. Or you may see that in your OPD, you have the attenders walking in and saying, we're having a lot of trouble dealing with her. So you have to counsel all those people, and they may be saying, like, my mom seems to be having a lot of mood swings, or my wife's getting very cranky on me. You have to assure them, tell them, look, this is because of the hormonal changes that she's going through. It is not her. She has nothing in her control. But you have to delicately see how much is the problem, and then decide what is the modality of treatment that you need to choose. Do you really have to go to a hormonal therapy, or can you give a local application? See her in whole. Don't, like, that's why I said, don't just give some applications, or don't just give her some hormonal therapy and send her back, because it can lead into or aggravate a lot of other problems. So you have to evaluate her CNS, make sure her vascular health is done, she has a good cardiac activity. Make sure if somebody is alcoholic, they do counsel them on the side effects of the alcohol, tell them what is a good amount that they can take, how much should they reduce, rule out do they have a hypertension, make sure their diabetes status is evaluated. All these things needs to be done, because if timely intervention is not done, we can have a lot of depressed women in the society. And female or the women forms a backbone of any family. If so, she is depressed, it gets reflected on everybody in the family, and in turn gets affected on their work as well. So evaluating, when especially we are in such a blessed field that we take care of the women, who's the core important person of the family. So trying to deal with them, trying to help them transit from a good phase to again another good phase, and let's not push them into a depressive state. So this menopause is a very big transition, where we have to really handhold the family and handhold her, and make sure all the cognitive changes go in a smooth fashion. We need to help her with a lot of psychological issues. So if they're having a lot of memory loss, make sure a neurologist see them. And this is exactly why I say multidisciplinary approach is very important. If there's a memory loss, try to see, give them activities which will boost their memory. A lot of women come back and tell us, I've been having no sleeps at all. These sleepless nights can be either because they have nocturnal urea, where they keep getting up in the night, and maybe again because of the burning sensation in vagina they have. Some people, because I told you, they put on a lot of obesity, central obesity, and this can keep leading into apnea. Sometimes it could be the chronic joint pain that they're leading into, and per se the depression itself may not be giving them a good sleep. And they are also, whatever said and done, mothers and women, their estrogen, even if the body gets deprived, they're always having that emotional attachment with their family. They start feeling that, I'm not able to give my complete self to them. This itself can becoming stressful for them. So a lot of negative mood swings, and they can lead into sleep deprivation, and again leading into depressions and lot of hormonal changes, which you already know. We've spoken about the hot flushes. So even in the night, your partner may be wanting to switch off the fan or the ACs, and the women may start complaining, look, it's so hot, why don't you on? And that itself can lead into a big argument, and lot of couple separating out, using different rooms because of the simple weather change, because she's feeling hot, he's feeling cold. That itself can become a disharmony between the two people, and sharing different rooms can be there, and sleep problems, them waking up again and again, can lead into a lot of mental trauma, which only gets added on. So make sure a multidisciplinary approach is done towards her. So you identify what is the problem. If you sit back with her patiently and take a good history taking, we can identify, is there a medical cause associated with her? Is it because of diabetes she's having nocturia? Is it a psychiatric problem that is associated with her insomnia? So if you really find out, you can really try to treat her. Like I said, first line of treatment, I would say, is always the best is the lifestyle modification. Concentrate on her diet. Ask her to start doing exercises. And this is one thing I always say: when you get old, you can't start doing an exercise. We cannot suddenly start telling a 45 or a 50-year-old woman, go do an exercise. You're having joint pain because you're just sitting or not doing much of an activity. We need to inculcate all these small habits from a very long time. When a woman starts coming to you, or a girl starts coming to you for her pubertal problems or the reproductive problems or post delivery, start catching them at that time. I would say catch them young. So start counseling them from that point of time. Start telling them, what does a good lifestyle modification mean? Tell them lifestyle modification is to do with your diet and exercise, a good exercise pattern, good diet. Of course, everybody can have their own cheat days, but then if you tell them the importance, and they all can move or go ahead with their perimenopausal, postmenopausal, and gracefully become older without much of a problem. Of course, this is inevitable, but we can definitely make the transition a little more smoother for them. And like I said, involve the psychiatrist if required to make her feel better, add some medications if it is needed, but then nothing compared to lifestyle modification, and counseling will take away half her problems. Talk to them about the yoga. Let's not forget about a lot of our ancestral gifts that we have got. A lot of therapies can definitely do a lot of problems. And like I said, when you involve the whole family and tell them why she is going through these mood disorders, why is she having irritability, why does she have a loss of control on her mood, why does she get upset very soon, tell the other people that it is all because of the fluctuating hormonal levels that is there. That is because of the neurological symptoms that she's going through. This is a transition in the neural system that of her brain. So all these problems will be there. So concentrate on the family as well, help them and make them understand if required. And if we have no choice, she has to be put on antidepressants, and counseling can be done. And over some time, with a lot of other lifestyle modifications, she can definitely be brought out and less dependent on the medications. But some complaints like the urinary symptoms will have to be going on medications for some duration. So here I told you urinary symptoms is all because of the estrogen loss, where it leads into thinning of the vagina, atrophy of the vagina, reduction in the fat, and this itself can cause a lot of burning sensation. Other than medications, you can also start thinking about vaginal regenerations. There are a lot of CO2 lasers available, Nd:YAG lasers available, where there are therapies available to prevent people from vaginal atropic symptoms, vulvovaginal problems. All this post-menopausal, perimenopausal symptoms can be reduced, especially the urge incontinence or the stress incontinence, because as the age increases, the estrogen comes down. So once this comes down, there's a lot of laxity in the vagina itself, and her support system also, bladder support, everything comes down. So then definitely she will end up having a lot of incontinence of the urine, sometimes stress. So sometimes it can be so devastating for them. I have families who come back and say she doesn't want to attain any functions because she doesn't want to use the diaper. Or of course we understand that there's a lot of inhibitions of using an adult diaper. Or she says, I don't want to go to any gathering because I have to use the loo frequently. So they start getting inhibited from a crowd and starts excluding themselves. That itself can become a grave dependency on the depressions, and this can lead into a lot of stress. So educate them about the Kegels exercise. This is why I said, as soon as your woman delivers, start talking to them about the Kegels exercise. Tell them the importance, so that way inculcate and educate them about a lot of importance through the next 2 or 3 decades that they will be facing. So if you try to spend extra 5 minutes post delivery and tell them the importance of lifestyle, exercises, Kegels exercise especially, we can help a lot of women from very early days and tell them what is the importance of diet and good exercises. Again, diet also indicates towards osteoporosis, because bad diet can lead into a lot of calcium deficiencies, and with the age we all know that the bone mineral density starts coming down. So even in the American women, forget the Indians alone, they are all women across the globe, I would say. So there is an increased risk of fractures because the bone mineral density starts coming down. So above the age of 50 years, there are almost 15 to 20% of the women more prone for fractures and hip fractures. We can hear, so little small falls, all these things can lead into fractures, and this is all because the mineral density starts coming down. And it's very important that you start checking for the scores and start early treatment. So people who are more prone are people who are of advanced ages. They do have, female itself is a high risk factors: tobacco chewing, smoking, increased weight, if they already have arthritis, all these people are more at risk. Alcohol intake, all these things lead to osteoporosis. Addition to it is osteoarthritis is something a lot of people at the advanced ages start going through, and estrogen deficiency only aggravates it more and more. So you can definitely add them on estrogen therapies, and you can reduce the inflammation and reduce the knee pain, and this can be even in the small joints like the fingertips, the toes, and even the major joints like the hip and the knee. They all can start suffering, and it's very important. And very important, like I said, whenever you decide to go in for a hormonal replacement therapy, please treat the women as a whole. It's not only the perimenopausal or the postmenopausal lady. Any woman who comes, even for a cardiac checkup, for an antenatal checkup, check her cardia. Just make sure you put your stet on her chest. You will be able to make out if there's any different sounds that you're getting. You identify a murmur, please send her. So evaluate her cardiac status, evaluate her neurological status, make sure her CNS, everything is good, because they can be prone for cardiovascular disease once you put them on a hormonal therapy. And all these heart diseases can be increased, and especially because of the age itself, it can lead into deaths as well for the hormonal therapy you've added. So make sure you evaluate them. And obesity, diabetes, hypertension can only make it worse. Concentrate on what is their lipid levels. Make them understand what is the good glycemic control they should have, what is the good BP recording that they should be maintaining, what is the BMI they are supposed to be having, what should their high density cholesterol should be there, what is the low density cholesterol to be there, what's the total cholesterol they're looking at. Tell them the advantages. Tell them at least you walk for 3 to 4 days in a week, that itself is good. Tell them even 150 minutes in a week, if you can walk, that is good. Tell them even 60 minutes, 1 hour in a week you start doing. This is why I said you can't start asking a 50-year-old woman to suddenly go for a walk. Inculcate all these habits much earlier. Please remember, whenever you are starting on HRT, all elderly age group itself is prone for cancers. We all know as a gynecologist that, breast cancer starts increasing as the age starts increasing. The chances are more. Colorectal cancer starts increasing. Ask them to watch out and ask signs like, did they see a blood in the fecal that they passed? Did they have blackish motion when they got up in the morning? So try to talk to them about these details, and that is how we can identify and make sure we don't put them on the wrong treatment or put on treatment which will aggravate the existing problems that they have. Make sure they're not suffering with endometrial cancers. This is why I said, if you are the one who's practicing and doing ultrasound by yourself, just to put a probe or get a scan done, make sure your endometrium lining is very thin. If you see transvaginal scans, if you see that there is an endometrial thickness more than 5 millimeters, tell them what it could mean. reassure them. You don't have to panic every patient who comes into. Tell them, look, if it is less than 5 millimeters, it's always good, but I am seeing that your endometrial thickness is a little higher for your age. If required, counsel them for a endometrial biopsy that needs to be done, so that we rule out endometrial carcinomas if they are dealing with, and this is how we can help them. Checking the ovaries is very, very, very important. This is why I said estrogen dependent tumors can be picked up quickly. Any pelvic pain, urinary urgencies can also be helped while doing these scans. So make sure, if a lady has never done and she came to you with perimenopausal symptoms, tell her, look, we have a screening for a pap smear, we have a screening for a cervical cancer. She wouldn't have done a pap smear ever in her life. Tell her what is the advantage. If you make her understand that these simple screening test of a pap smear can pick up and prevent them from developing cancer, anybody would agree to do it. So tell them what is the importance. Start talking to them all, even in the reproductive age group, and tell them pap smear is something very important that at least 3 yearly once you start doing, once you're sexually active. If the lady who's approached your OPD is more than 65 years, and if she's done 3 pap smears and everything has been normal, then it is okay. You can ask her to come back after 3 years and do another one. If the lady is already above 65 years, then she doesn't have to do any pap smear, because the chances of cervical cancers are very less. But it's still mandatory that you check her cervix. If you see a cervical erosion but she's never done, there's no harm in taking up one cervical pap smear to rule out cervical cancer. If you could accidentally detect a growth there, so it's very important that you check the cervix. And if somebody has done a HPV testing in the last 10 years and 2 have been normal, that's wonderful. If it is abnormal, then we'll have to look into it and start recognizing and going it. So let's talk about the treatment per se for these people. We've already spoken about the holistic approach, the counseling, multidisciplinary. But what do we do as a gynecologist? How do we help them after ruling out all the associated complications or associated problems and making sure that she's good? Yes, definitely the first role will be hormonal replacement therapy or the treatment protocols that after the lifestyle modification and all. I'm talking about the treatment per se. So here, when it comes to hormonal therapy, we can be choosing either the tablet, the patches, or the cream. So I would say let's go from below. So let's start with the cream first. This is the easiest. So talk to her. If you find out it is just some vaginal dryness, vaginal atrophy that she's dealing with, or dyspareunia, give her a cream. Ask her, call her back. Never see to it that she's not lost. She shouldn't be lost for follow up. So you trace her, especially when you put them on hormones. They can be using the same prescription again and again. Tell her what all the complications can be there, and she will definitely follow up with you, and she will never fail to not come and show the same prescription and keep buying. So just the estrogen can be used as a cream, or even if you're looking at tablets, you can have put them only on estrogen. Sometimes the estrogen and the progesterone needs to be put. So it depends on what is her age group, what is the problem that she's suffering with. Is she a perimenopausal or is she a postmenopausal? So the easiest chart I would say is this: if somebody has a uterus and they've not had an hysterectomy, then you can think of combining an estrogen and a progesterone. If somebody has already gone through an hysterectomy, then just think about putting an estrogen is good enough. So if the vaginal estrogen therapy is useful, that's why I said put local applications like the cream if they're just complaining about a vaginal dryness. So all these things can be tailor made to each patient. So you can choose between the tablet, the patches, the cream, and that is how you can go ahead with that. And please explain to her and document. Very important. We are in the era of legal litigation. So if and whenever you are putting on any hormonal therapy, be it the tablet, the cream, or the patches, tell them what is the risk factors associated with the hormonal therapy. Tell them they are prone for endometrial carcinoma. The worst is the venous thromboembolic diseases. Tell them the symptoms, that if they are put on some pill, if they start getting a headache, blurring of a vision, not to sit at home thinking it's a migraine. So ask them to report back quickly. Some people end up having a lot of vomiting. So tell them, please report to the emergency and get yourself checked, because that could be one of the complications of the hormonal therapy you put in. Also tell them there's a little increase for breast cancers that can be there. So regular counseling for a mammogram is very, very, very important, especially after 45 years of age. Tell them every 2 to 3 years they should be getting an X-ray mammogram done. Ovarian cancers risk are higher. Cerebrovascular accidents can be seen when people are on hormonal therapy. Lipid metabolism can change. And there have been a lot of studies which say, yes, there have been a lot of CVS complications, thromboembolism, breast cancers have increased because of the hormonal replacement therapies. To be on the safer side, because if they are suffering, we have to go for a hormonal replacement therapy. So you need to counsel and then choose what is the best among that. So you can be using a conjugated estrogen with the dosage of anywhere between 0.625 to 1.25 milligrams per day. And a lot of them do wonderfully well with 1 or 2 tablets per day. You could also be using a medroxyprogesterone, which is more safer of the progesterones, where from 100 to 300 milligrams per day can be used. But don't forget to counsel them about the side effects that is associated. Try to put them on a shorter duration, and don't give it for a very long duration. Give it for a short period of time. Tell them stop it, see how you feel. You can always come back, and a low dose oral conjugated estrogen can also be effective, where you can use 0.3 milligrams is very good. You could be using progestins, where, and this is also very helpful in with breast cancers or endometrial cancers, because they can help them reduce the hot flushes as well, and also prevents them from developing osteoporosis. Again, medroxyprogesterone of 2.5 to 5 milligrams per day can be used here. Tibolone is one wonderful medication, I would say. It's a very low estrogenic and a progesterogenic. It also has the androgen properties, and this will help them from the atropic changes of the vagina. This will prevent them from osteoporosis. This will prevent them from hot flushes getting developed. A lot of increase in the libido will be there. All you have to start them with single dose of 2.0 milligrams per day, and then lot of symptoms can be there. These are the different prescriptions we can be using for the treatment, but it is very important that you explain them the side effects. This is why I said a lot of bowel irritability, nausea, vomiting, insomnia, and decreased libido, dryness in the mouth, dizziness, nausea. All these things can be there, and it's very important you ask them to report as soon as they find out. Time and again, or decades together, we've been telling people, take a lot of soya, take a lot of phytoestrogens, do this, eat soya, take isoflavones. We've been talking about it for quite some time, but unfortunately there have been a lot of studies which says isoflavones haven't been very good in preventing this perimenopausal or postmenopausal women with osteoporosis reduction or osteoarthritis reduction, or not helped much with the hot flushes. So think, are we giving them unnecessary medications by simply writing a prescription of an isoflavone is very important. So any medication that you use should have a regulatory endogenous estrogen to non-reproductive organs and reproductive organs. It should give them a good symptomatic relief, and also make sure we are not putting our women at higher risk for cancers or thromboembolic disorders or the stroke which can be associated. So we want a medication which has got an upregulation on the non-reproductive organs, but a downregulation on the reproductive organs like the breast, the endometrium, and the ovaries. There have been a lot of herbs which have been used, like the cinnamon, the methylestrase, and the Cinnamon wilfordi, Agnes gigas. All these things have been proven to be working. But then how do I write this prescription for them? It's like me trying to tell them, go to a Ayurveda shop and ask for these ingredients. I myself cannot pronounce these names. So how will I tell my patient, go there? And being an allopathic specialist, we cannot tell them, go and eat these herbs or take this. I've always wondered, why can't some company come up with these things? So there have been humpty number of studies how this herbs, the cinnamic acid and angelica gigas have been working wonders to help our women. reduce a lot of complication which is associated with the estrogen, but non-estrogenic harmonic regulator, we would call. We do have a product from the Shield company where it is wonderful for the perimenopausal and the menopausal women to relieve their symptoms, where there is no affinity for the ER alpha or the ER beta cells, but working wonderfully well. The upregulation and the downregulation on the reproductive organs are balanced very well, and I'm definitely in love with this product, and it works wonderfully well. I've had a lot of patients who come back and give a positive reference, and tell them that, compared to when we put them on isoflavones, these products have been working well for them. To support not only my love for this product, we also have a lot of evidences which says that they have done a trial with placebos and a lot of these medication, and they say it has worked very well. There have been evidences where they have shown that the vaginal dryness is less, hot flushes have come down, mood swings have become better, bone pains have reduced, and they feel symptomatically better. Can you believe, in 15-20 days people have come back and told they are feeling wonderfully well. Their bone mineral densities have got better, and they can see that all these alkaline phosphatase have come down, the lipids have become better, the person itself starts psychologically feeling so much better, bone mineral density has become good for all these people, and they see it's wonderfully well, especially the, like I said, the hot flushes, everything have got better, and some people have used it for a longer duration of time, and they say they are feeling wonderfully well. The transition has been very good for them. But of course, nothing can be a substitute to exercise and eating right. So make sure you educate them, tell them what is a good lifestyle modification. This is why I said don't start later, catch them young, start training them, telling them a physical activity, targeted exercises. Some lot of women, not some, lot of women come back with back low back aches. They keep coming back to us, they keep saying joint pains. Counsel them, tell them, look, start doing back strengthening exercises, concentrate on your nutrition, avoid alcohol, tobacco, reduce your stress, start doing meditation. Tell them to choose good hobbies, ask them to start concentrating on their nutrition. Like I said, family involvement in the counseling, spiritual attitude, getting a good sleep, and helping them will really help them. And if you teach them and give them this pyramid of what could be used at the least, how they can concentrate on taking more of cereals and millets, considering a good portion of vegetables and fruits in their diet, the milk products quantity doesn't have to be too huge. Let them have a balanced diet, and their calcium in the dietary intake can be concentrated. Counsel them the sugar intake has to not be more than 6 teaspoons per day. Salt intake also has to be reduced. Of course, oil is required, they don't have to go oil free. A little amount of oil is definitely required, a good portion of fruits, vegetables, lot of water. Now a lot of our body itself is made out of water. We need to educate people, and you have seen in your daily practice that we have a lot of women, yes, I drink water, especially because people coming up with vaginal urinary tract infection, vaginal complaints. If you detailedly ask them how much are you drinking, it will definitely not be more than 1 liter. And I don't know if I can ask this question, how many gynecologists are actually drinking adequate water? We ourselves starts need to be doing, and that is how we need to set an example, telling that minimum 3 to 4 liters of water is required. That is when the skin can be very well hydrated, all the chances of you getting wrinkles, everything is going to come down. Tell them, of course, do take flax seeds, cinnamon seeds, fenugreek, soph, add it in your salad, curd, soak it overnight. Try to tell them to make it more interesting, add it up to the smoothies or the milkshakes that you do. Ask them to add the cinnamons, everything into their coffee or the tea that they add, increase the extra flavor. Increasing this homemade remedies can also help them. Tell them to cut down on the caffeine and the tea that they need to be taking. Tell them, they can have a curd which has got a good amount of calcium itself. Tell them reduce the instant coffees, because if you get busy and you start adding instant coffee, tell them not to increase more than 65 grams, and tell them, consume good amount of curds and milk, and this helps them build the calcium in their body. Tell them to consume vitamin C rich fruits and vegetables, which will also in turn start helping the calcium absorption. Tell them that they need to get adequate sleep of minimum 7 to 8 hours of good sleep is a must. Try to keep away from the light, or tell them don't have large meals. Exercise is very good. Tell them avoid caffeine in the evening, especially. And since a lot of women have nocturia, tell them after 8 or 9 o'clock reduce your water intake, and this will help them come down using the loo more frequently. So see, for the osteoporosis also, make sure you don't only give them these holistic approach. If required, please add them on the calcium. So do their bone mineral study and see if they are in osteopenia, or are they suffering from osteoporosis. Are they suffering from severe osteoporosis? Are they prone for fractures? Talk to them, add them if required on the tibolon, add them on the bisulfonides if it is required. Tell them about the lifestyle modifications that they need to be doing. Add them on the calcitonin if they are suffering from severe osteoporosis, because post-menopausal women have a fragility and they're more prone to fractures. Talk to them, add them on vitamin D, add them on calcium supplements, get their investigations done. Tell them, come back, we need to check on your bone mineral density again. Teach them the importance of physiotherapy, rehabilitation. Emotional comfort is very important. It's not just we need to be mocking at them. Of course, they've approached to us a little later. You can't mock that, oh, now you can't do it. Be supportive to them, give them psychological support, seek a social support, make sure you involve the whole family, and make sure they're relieved with their work and they get some time for themselves so that they can concentrate on the exercises that they need to be done. And also calcitonin will help a lot of pain relief in the vertebral fractures as well. When you're adding a calcium, make sure at least 800 milligrams per day is added, and the upper limit is 2500 milligrams per day. Don't unnecessarily load them with calcium. So make sure the RDA is adequately done. Vitamin D needs to be added. Anywhere between 1500 to 2000 international units is good enough, not more than 10,000 international units. So check the elemental calcium. The good ones are the calcium carbonates and the calcium citrates, which is good, where the elemental calcium is between 40 and 21. But then if it's calcium carbonate, what happens? It needs an acid to dissolve. But if it's a calcium citrate, they do not require any stomach acid for the absorption. Citrate is good for the people who are above 50 years. They have a better absorption. And calcium carbonates can be taken with the meal, but the citrate can be taken at any given time of the meal. But citrate is a little more expensive compared to the calcium carbonates. So adding a calcium supplement is very important. Like I said, treat the woman as a whole. Make sure she's not suffering with a thyroid disorder. Does she have a corticosteroid issue needs to be done? Tetracyclines, anticonvulsant. What is she taking? Check her. Does she already have a hypercalcemia, so that we don't lead into some renal insufficiency, and lot of nephrotic problems shouldn't get added. So make sure that she have a good absorption capacity. And once you start concentrating and check on the previous medication she's already taking, we'll do a lot of justice to the treatment that we are adding. If somebody's bone mineral density is very low and they cannot take a tablet, or we can't add, or we need to help them much quickly, they can definitely go in for injectables. But then I always say, adequate treatment, if timely started, they don't have to go for injectables at all. The sachets and the tablets itself will do a lot of wonders. And do not forget to add a maintenance therapy for these people to correct the deficiencies. And this is why we say, cholecalciferol tablets of 60,000 international unit, once they're done with the course of twice a week and then shifting on to once a week, it can always be put on once a month, and then keep following it up. And if you're adding a vitamin D, make sure that 1000 or 2000 international units per day is achieved. But if you have no choice but go for the injectables, 3 lakh international units IM twice a year, you can give them. Okay. And very important, please watch out for the thromboembolic risk factors. And especially in this COVID times, that because of the COVID pandemic, what happens? People are more prone for thromboembolism. You've already put them on an HRT in the last year or the last wave. And then now if they've been diagnosed to have, make sure you don't have to stop their hormonal therapy, but prophylactically you can add them on low molecular heparins. But then if they are on the higher hormonal therapy, shift them on to a milder ones like the tibolon, or like I said, for some time on the medroxyprogesterone. but make sure you, if required, or they have been diagnosed to have COVID-19, they have been put on low molecular weight heparin is very, very important. And very important that you evaluate their diabetes and hypertensive status, talk to them about it, and make sure you can shift on, instead of the oral hormonal therapy, you can shift on to the dermal patches or the local applications. Depending on her symptoms, you can alter that. So make sure you treat her as a whole, concentrate on that. Especially we have to be very careful in this COVID times. Coming to almost the end of my talk, let me talk to you about the take home message for this talk of mine today. Target the population for initiation of the hormonal therapy within 10 years of the menopause. Talk to them. Early post-menopausal period treatment, women can be treated more effectively. And if you start hormonal therapy and its uses are appropriately used and used for essential women, they don't have to be suffering from the menopausal symptoms. And we have good options for using hormonal therapy. Choose the right woman, the right age, the right hormonal therapy, right doses, right route. You will definitely have a healthy woman. And with this, not alone us, let's also help our women coming for our help, also help them gracefully become older. And in this pandemic, I only request we as healthcare workers or the COVID warriors, let's all stay safe, let's stay healthy, let's continue to maintain the social distance, let's all connect online for some more time for this educational exchange. Make sure you continue to wear your mask, wash hands, and get vaccinated. I'm sure all of you are. If anybody is not, please do not miss the opportunity. Get yourself vaccinated. Thank you for your time.
Thank you very much, ma'am. Thank you very much for this nice, informative, and in-depth talk. And madam, meanwhile, I have received few questions.
Please tell me. Suman, I can't hear you.
Yes, ma'am. Hello.
Yeah, I can hear you now. Please tell me.
Yes, ma'am. This is a very nice talk. Thank you very much for that.
Thank you so much.
Meanwhile, I have received few questions from the participants.
Please tell me.
So if you allow me, then I will start that one.
Yes, please continue.
Madam, actually, we have understood that hormone therapy is the hormone HRT therapy is the main choice of treatment in case of menopause. But there are some issues with that also. And in case of non-hormonal therapy, there is not sufficient data on that for the improvement. So, what is the best management for the women in such kind of scenario? How do we prioritize the relief of the particular patient instead of avoiding the risk associated with the HRT?
Yes, so this is the medication that I was talking to you about, the estrogen that the Shield has. I think works wonderfully well. So you'll have to see what is the symptom that she has come up with. So if she's only suffering through a vaginal dryness, you can start giving them a local estrogen cream to be applied. If it is she dealing with the hot flushes, then you can write the medications. Like I told you, the estrogen can be used twice a day for her, and they will feel a good relief. And if it's about dyspareunia or vaginal atrophy, that they are going to, the alternative method you can do is the vaginal regeneration therapies are available. So you can start working on this. There are a lot of patches available. This is exactly why I told, whenever you're putting them, any women on a hormonal therapy, please make sure you rule out any associated complications. Is very, very, very important.
Okay, madam. And another question is that there are many women who are hesitant to talk about dyspareunia and feel like that this is something that they have to live with. So, are there any specific strategies or therapies available for managing other than estrogen pills or creams?
Yes, definitely. So it's a good question. And I'm also specialized in aesthetic surgery, and I've been trained in this in Israel. So, of course, the vaginal creams work wonderfully well. The estrogen creams wonderfully well. You can, if some people are at high risk, you can always use a vaginal lubricants for them. So I do this vaginal laser therapy for them. Works wonderfully well. We advise 3 sittings monthly gap, 1 month gap between each doses, and we say booster dose. Again, around the 4th sitting can be done. But I have seen, and we have done a study of 25 women. and almost 22 women didn't need another sitting at all. So they came back and said they were almost feeling 80% much better with the vaginal dryness, the atrophy. The urinary symptoms had come down. Quite a few of them had felt 70% better with the stress and the urge incontinence. So this works by increasing the collagen tissue, and also the edema of the vagina increases. This can be wonderfully well, and an alternative method to the hormonal replacement therapy can be worked.
Okay, madam. And madam, one question is, can estrogen be used 5 to 10 years post-menopausal, and how long?
Okay, so I don't know if this question is saying, can we start at 5 or 10 years? Definitely. If the woman approaches you 5 years later or 10 years later, it can be used, but provided, because it's a local application, it should not cause any systemic effect, but she will definitely start feeling better. But how long to use? So I always tell my patients, with the estrogen, you get a applicator, so you use it on that, apply it on the vaginal area or on the skin surface very close on the inner thigh or something. You can start applying there, so she'll start feeling better. And once she starts feeling better, you can reduce, slowly taper it down, and then tell her to observe and restart if required. But most of them do well.
And ma'am, how long can we give calcium supplements in postmenopausal women? Is there
So
any?
again, this is why we should initiate them and counsel them about the good diet that is required. The calcium, for every diet they consume, they need to be having awareness about the calcium consumption. Definitely you can go on for a longer time. Remember, I told you, if you're putting them on a cholecalciferol, you can start, if they're deficient, you can start it with twice a week for 2 to 3 months, then taper it to once a week, and after that you can just add it once a month. And for some time you can always regularly check, and I'm sure all of you at a certain age group, 45 plus, yearly check is very mandatory, so you can keep checking on their vitamin D levels. Add them on vitamin D, 1500 to 2000 international units per day. If it is good, you don't have to unnecessarily add them, so you can always defer, keep checking on them, and alter the dose adequately.
And madam, one question is from my side, that in case of early menopause, means say it is early 40s or something.
Yes.
So that time lots of life is remaining still. So in that case, what is your advice and the treatment strategy for that particular kind of?
If it is very early, we have to remember these are premature ovarian failures. So these people, of course, it depends on what are you looking at. If it's premature ovarian failure and you're still looking at fertility, we'll have to approach in a different way, where we'll have to start looking for oocyte donors. But if you've already completed your family luckily and you've attained a premature menopause earlier, then we'll have to start going. So you'll have to rule out all the systemic problems, like is she diabetic, hypertensive, is she obese, and judiciously use the hormonal therapy. If she is diabetic or a hypertensive, or she has a DVT or a CVT family history, or herself has a higher risk for thromboembolism, you can go for the non-hormonal therapies, which I've already mentioned. If she has no associated systemic problems at all, definitely a good estrogen therapy can be added for her. If she's looking at regular menstrual period, it is good to add estrogen and progesterone, so she'll also feel very happy to get her menstrual cycles at least once in a while, and that works wonderfully well for her as well, psychologically giving her comfort. But if she's not very comfortable, then just the estrogen therapies, like I said, the low estrogen androgenic added progesterone one is the Tibolon, which can also be used.
Madam, Dr. Shubha asked one thing, that in future she wants with you for a session with prolapse uterine, and she wants to know whether prolapse uterine is related to menopause or not.
Yes, what happens, Dr. Suma? So as the age increases, definitely this estrogen starts coming down. Once the estrogen starts coming down, the muscle laxity sets in. We have to remember the collagen starts reducing, the estrogen starts reducing. So there is no water retention. So all the while, so what happens? The muscle starts becoming weaker, and this can lead into prolapse. This is exactly why I said post delivery, you can start talking to them about Kegel's exercise. So mild prolapses can also be prevented. So lifestyle modification, all these things become better. As people become menopausal, obesity sets in. These can all be aggravating factors to menopause, obesity, reduced estrogen, increase in weight can all become an aggravating factor for the prolapse. And of course, we'll be happy to do a session for you sometime at the prolapse.
Dr. Aditi Rai also complimented for that. Yes, that is very useful lecture, and thank you so much, madam. And another query is, what is the duration of Libolon therapy?
Or Tibolon therapy. So what happens, very important, that whenever you put your women on hormonal therapy, you have to do a regular follow-up, call them back always. Like I said, keep doing her pap smears, keep talking to her. I somehow am not a favorite that they go on for a very long duration of time. Give them on and off, put them on 3 to 6 months. 3 months, I would say, is better. Keep them off on the hormones, see how do they feel. This is why exactly spend time in talking to them about the lifestyle modifications. And then again, you can start calling them back. If they're feeling better, why put them on any of the estrogens? This is why I said Tibolon is good, because it's a low estrogenic. So the complications are much less associated with it. If they're not feeling better, give a gap and restart. So by the time you call them back, they see you and you talk about it, they would have got a month or 2 gap. And if they still are not feeling better, you can ask them to restart. So this is how you can go on and off for them.
And I could not see, ma'am, any other question. So thank you very much, madam. Thank you for your valuable time.
Thank you, Suman, for organizing and coordinating this whole program wonderfully well. Thank you, Shield.
And another thing, I want to request you, if you have some time in near future, so we shall have a session on that prolapse uterine. If you permit us, we will definitely organize that.
Sure, we can look into it. Thank you so much.
Thank you, madam. Thank you very much.
All of you have a happy week. Stay safe.
Thank you.
Okay. All of you take care. Bye-bye.
Thank you, madam.
Thank you.
Thank you. Bye-bye.